I'm Kaitani. Please confuse my name to exchange order. So I would like to present our second randomized study, EAST-F trial. Let me begin with a brief background. Transient atrial tachyarrhythmia occur frequently in the first few months following the ablation. A sizable portion of early recurrence is related to the irritability from the ablation procedure. This phenomenon is a strong predictor of later recurrence of atrial tachyarrhythmias. Therefore, we hypothesized that 19 days use of antiarrhythmic drug following the AFib ablation could prevent early recurrences and thereby promote reverse remodeling of the left atrium, leading to the improved long-term clinical outcome. In the EAST-F trial, we randomized the patient after the successful AFib ablation. Finally, 2,038 patients were randomly assigned into the AAD group and the control group. For the patient in the AAD groups, Bogan-Williams class 1 or class 3 drugs were started from the standard dosage immediately after the procedure. 1 year follow-up data was completed in 99.2% patient. We observed atrial tachyarrhythmia recurrences at 1 year with a blanking period of 19 days, and those with within a blanking period of 19 days as a secondary endpoint. Baseline patient characteristics as shown in this table. As with under ATB trial, there are significant differences in the age, gender, and the age-related specified variable. So in this presentation, we show the endpoint adjusted for these age-related specified variable by Cox proportional hazard model. This shows the medication at discharge. Except for the class 1 or 3 drugs, there were no significant differences in the use of the medication, including a beta blocker. This pie chart displays use of rate of antiarrhythmic drug used in the AAD group. As you can see, 75% patient received class 1, 25% received class 3 drugs. This slide shows the arrhythmia-free rate curves during the blanking period. Significantly greater number of patients reached a secondary endpoint. Arrhythmia-free rate at 9 days was 59% in AAD group and 52% in the control group. Relatively, this reduction rate was 40%. But if I look at the primary endpoint, however, there were no significant difference at 1 year follow-up between the two groups. As with this finding is consistent if a patient subdivided the type of AF. We also assessed the safety of this trial. Regarding the procedural adverse event related to the adverse event, there were no significant differences in between the two groups. Evidence side effect of the antiarrhythmic drug requiring exchange or discontinuation of AD is observed in the 4.1% without any serious complication. This study, including several limitations, in those, including those associated with the randomization, and there might be have been the differences in the recommended AADs and their dosage between the present study and the Western AF guideline. So I would like to conclude this presentation. First, short-term AED treatment for 90 days following the epi ablation significantly reduced the atrial tachyarrhythmia recurrences during the treatment period of 19 days. However, it did not lead to improve the clinical outcome at 1 year follow-up. Thank you for your attention.
These two studies are open for questions together. Perhaps Dr. Kaitani could come to the podium as well.
Go to the podium also so you can answer both questions. Go ahead.
Please.
This question is for Dr. Kabari. I presume you're familiar with the advice trial that was published in The Lancet a few months ago. Your trial seems to have assessed more or less the same thing but had very different outcomes. Do you have any idea as to why that is?
Yeah, very excellent question. Thank you. It's a very different type of trial of design. Advice trial has including a patient of only paroxysmal, and they do only pulmonary vein isolation. But we are setting this in this presentation. We do not only pulmonary vein isolation, but also many type of ablation strategy, and for any type of atrial fibrillation patient. And there is many other differences, but it's the most difference point. Thank you.
Could we just get one point of clarification here? It's really for both of you. So this was a factorial randomization. It's the same 2,000 patients, and they were divided into 4 groups under ATP. And so was there any influence of the ATP testing or antiarrhythmic drugs? Did they interact in any way? Did that influence your analysis?
Actually, we can't find an interaction between these each randomized study. But before we launching the study, we of course discuss with the statistician. But fortunately, we could not find the interaction.
So there was no interaction
Yes.
that you found. That's gratifying because it gives us a measure of confidence in the observations.
For the first study, could you explain the rationale behind identifying adenosine and how that leads you to the dormant pathways, and also how you went about identifying the adenosine?
Thank you for your question. I think actually ATP is a power to unmask dormant conduction. It's real. But it's not strong enough to unmask almost all hidden gaps. So we think it's not so necessary. It's not so always necessary to test by ATP. Before ATP test, we should do to create durable region for pulmonary vein.
Can I ask something? You show no difference in the follow-up between ATP and no ATP, but do you have data of redo procedures in pulmonary vein reconnection? There were more reconnection in the ATP versus no ATP? In the number of PV reconnection?
In the second session?
Yes. In second procedure, yeah.
Oh, I'm sorry, I have no data available now.
Okay.
Okay, thank you very much. If there is no further questions,